I'm very privileged to be able to start off this conference. I want to give you a little bit of a history about what I'm going to talk about, which includes a little bit of a history of our organization and a little bit of history of myself. I'm a general internal medicine physician. I trained at the Yale School of Medicine during my residency program, and I did a Master's of Public Health after my residency and took jobs in the community taking care of patients as a general internist, but also in working to develop our quality infrastructure. This was back in the mid-1990s when the patient safety and clinical quality movement was just beginning to get going. And I think there is a saying that we used to talk about in embryology, which is ontology recapitulates phylogeny. And I think that there is a commonality in that between how we think about our journey to quality and safety, each of us in our own clinical practice, in our own organizations, but also how it has played out in history. And so my talk today is going to be around how we consider approaching quality and safety, the most important thing we do for patients, giving them safe, high quality care, and how we embed that in our clinical practice, and how we do so at a scale of an academically based health system that spans a geography of about 100 miles, 30,000 employees, 7,500 physicians, and more than 3 million patient contacts a year. And this is a talk in evolution. I've been evolving this talk for the last 30 years, and I have 1 hour to pack 30 years of talk into. So I'm going to go very quickly. I'm going to touch on some historical events, and I'm going to give you some ideas. And I'm always happy to engage any of you in conversation about any of these topics afterwards, if you would be so interested. So as I mentioned, we're a very large system. We have 100 miles of coastline of the state of Connecticut that we cover. We have 5 hospitals, which encompass 7 acute care hospitals, more than 300 sites. We provide more than 3 million outpatient encounters a year. We have 2,681 beds, and those beds right now are full across our health system. We have 30,000 employees, and we have 2 physician groups that work, essentially 2 physician groups that work within our health system. One are the faculty of the Yale School of Medicine, most of which are based in New Haven, and that's historically where our large academic medical center was. But increasingly, our physicians are spread out across our health system, like Bernardo, who works primarily, but not exclusively, out at Lawrence Memorial Hospital, which is a hospital in our eastern coast. We've been very deliberate about this because we believe that if we are going to act as a health system, as an integrated health system, we should expect that the same high quality care in the same way is delivered to everyone who seeks care in our organization, regardless of which one of the 300 sites that they touch within our health system. That's a very different model than where we were 10 years ago. 10 years ago, we were a holding company, which is we had all of these assets, but everyone did everything completely differently. And over these last 10 years, our desire and our ability to establish that we are doing everything the same way has increased astronomically. And it is our goal that we develop what we're calling a care signature. And I'm going to use that word a lot today, meaning that no matter where you go, no matter where you access us, if you see our brand, you are guaranteed the same access to high quality, safe care, no matter where that is. And that's a real challenge. And I think we've set out a challenge that I don't think very many academically based or even non-academically based health systems have been able to make good on in the United States. There's a lot of talks on quality, and I think acknowledging one thing is quite important, and that is humans are fundamentally flawed. And Jerome Lederer is arguably the founder of aviation safety. He was in charge of the United States Federal Aviation Administration in the 1960s. And in the 1970s, he was in charge of safety for NASA in the United States. And as you know, we have been on a safety journey in healthcare ourselves. And we have been developing what we call it being a high reliability organization, something that aviation, nuclear power, other organizations have really almost completely achieved. And I think this is important. Jerome Lederer wrote, "The average man has only one head, two eyes, two hands, and 2 feet. His response to demands cannot be guaranteed within 5%. His temperature cannot be allowed to vary by more than a few degrees. His pump must operate at a constant speed and pressure. His controls are subjected to fatigue, illness, carelessness, anger, inattention, and impatience. This mechanism was originally designed to operate in the Stone Age. It has not yet been since improved." Now, what this fails to recognize is the indomitable human spirit to want to improve and human intellect in the capacity to unlock secrets. The problem is it's variable. We all have different capacity, and we celebrate our diversity. We celebrate what we each bring to the table somewhat different. But how do you take the concept of that difference, that diversity, that difference that we all have in our ability to think things, our ability to figure things out, yet translate it into consistency in the application of clinical science? That's a challenge, and that's a challenge we all face, and I think we haven't discussed it enough. Now, you layer on the human frailty onto this, onto this, which is the doubling of medical knowledge. And we are just inundated every day. And one of the reasons we are here is to share with each other advances in medical knowledge. In 1950, the doubling of medical knowledge happened every 50 years. In 1980, that had shortened to 7 years. This paper is from 2011. The status of doubling of medical knowledge in 2011 was every 70 days. With COVID, monkeypox, and all of the other things that have happened over these last 3 years, the doubling of clinical knowledge is now estimated to be every 14 days. With genomics, genetics, unlocking the key mechanisms for physiology and pathophysiology, there is no way that creature, man or woman, who was created in the Stone Age can keep up with what's going on in medical knowledge. That is true. But yet we all do, because we are blessed with the diversity of thought. We are blessed with all of us that are interested in so many different things, as characterized by you all. And I can just point to our team from the university, which is we've got cardiac surgeons, we have mitral valve experts, we have heart failure experts, imaging experts. But if you try to cross that, if you take our mitral valve surgeon and ask him to perform echocardiography, I guarantee you, sorry, Arner, it will be a dismal failure, because we all need to apply what we know best, but then we need to apply it consistently. How do we do that? That's our question that we need to solve. So all of which I described has put us in a state of clinical quality that I don't think has changed in 25 years, which is we are all working extremely hard on improving quality. Yet, despite our best efforts, we have both serious preventable complications, falls, pressure ulcers, infections. We have underuse of effective care. Bernardo is going to give a talk on the advances in hypertensive treatment, yet we know we apply them unequally to populations. We've known since the Framingham study the importance of target blood pressure readings. We have the drugs, we understand the mechanisms, yet there are large segments of our populations that are not treated appropriately. We've known since the Scandinavian simvastatin trial, the 4S trial in the early 90s, how important lowering cholesterol is for prevention of cardiac events, yet large swaths of our populations do not get appropriate cholesterol treatment. We know for decades, that aspirin used in the treatment of acute myocardial infarction has a number needed to treat of about a dozen to lower and reduce mortality. But we don't use it regularly. Why? There are these huge gaps between what we know and what we apply. And we have work to do both in that underuse, but also overuse. We overuse imaging technology. We overuse certain surgical procedures, and that drives unnecessary healthcare costs, and it prevents us from applying things to other patients that need them. And we have unequal treatments by population. So I would make an argument, for the purposes of time and to be expedient, is that we've made incredible movement in reducing safety events. We've been hyper-focused on safety since the year 2000, when the To Err is Human was published in the United States by the Institute of Medicine. And we've applied high reliability science to healthcare. Where we have made very slow progress is on underuse, overuse, and equity. So we are undertaking a project. 3 years ago, we recruited a person from the Mayo Clinic, Dr. Deborah Rhodes, to build clinical care pathways inside of our electronic medical record to drive what we are calling care signature, which is that expectation that no matter where you go, if you present with a clinical condition in our health system, you'll get the same equitable care. So it is that care signature work is intended to bridge that gap between efficacy, what we know works, and effectiveness, what we actually deliver to the patient. And I will make it as a broad statement, because no matter what you look at, you can demonstrate that we know far more than what we actually apply to patients, and we apply it unequally. And this concept of care signature is we can use clinical care pathways built into our electronic medical record to drive consistency in medical care, to increase the effectiveness of our knowledge, of our treatments, of our protocols, and have a feedback loop to then ask additional questions. As physicians, we are outstandingly interested in what works. We love mechanistic questions. We love mechanism. What we don't like, and what the historical scientific community has undervalued for decades, is implementation science. Once you know it, how do you apply it? That's not very interesting. It doesn't get you promoted. It doesn't get you published in journals, but it's the most important thing if you are going to help that patient in the bedside. So it's left people like me, administrators, not scientists, to figure out how we bridge that efficacy effectiveness gap. This is the state of clinical care prior to last year for us. I had recruited Dr. Deborah Rhodes to develop Care Signature. We had a quality and safety team that was working on quality and safety projects, and all of these other projects around patient experience and trying to improve the provider engagement and reducing our infection rates. And all these other projects were impacting the patient. And it was just cacophony. You had so many things going on, you just couldn't sort it out or reliably expect that all of these things were helping patients. We've since reorganized everything through Care Signature, everything through pathways, so that quality and safety, health equity, our provider, our physician and clinician experience, all of our clinical operations work, which is including smoothing how we do length of stay, smoothing how we do admission and discharge, how we're getting access for patients into our institution, and also things that are financially impactful. How do we use drugs? How do we get at true overuse of clinical diagnostic imaging, medications, treatments, and so forth? All of that can be impacted and influenced through our clinical care pathways that are built into our electronic medical record. So enough about that. Let me give you some nuts and bolts. This is the important slide about how we build a care pathway. It all starts with you. We convene what's called, there's 6 steps. First step, we convene a clinical consensus group that decides what we're going to do around a specific condition. And then we charge that clinical consensus group with going through the literature, understanding what's right, what's best practice, what's the current gap between what we do and what's expected. And then we build those clinical pathways. We embed them into our electronic medical record together with all of the order sets. And then we allow broad review of those, and then we implement them and then measure how they are doing. Those of you who have done quality improvement know that's a classic PDSA, Plan, Do, Study, Act, quality improvement methodology, where you talk about what you're going to do, you actually look in why you should do it, you define best practices, you do it, and then you measure your results, and then you start over again. So that's what we do. So here's the first 2 years of our care signature work. We recruited Dr. Rhodes in March of 2020. Everyone knows what happened then, but she was able to get this launched in March of 2020. And by October of 2020, we had our first care signature pathways in our electronic medical record. It took us 18 months to get 100,000 uses of our pathways. And then over the next 2 months, we got to 200,000. We doubled in 2 months. Everyone can see the spike in January of 2021. In January of 2021, that corresponded to a spike in COVID cases in our institution. Why is that important? It's because COVID was a new disease. None of our clinicians knew how to apply any of the clinical care protocols, any of the drugs. So everyone used our pathway. It was a light bulb moment, an aha moment for us, because what we realized then, which is for new conditions where clinicians didn't know what to do, they were happy to pull the pathway. So for monkeypox, for COVID, they were happy to use the pathway. They were not happy to use the pathway for conditions that they thought they knew the best practice on: heart failure, pneumonia, cellulitis, chronic obstructive pulmonary disease. Every clinician in our institution, seasoned clinicians, thought they knew the right way and they were up with the literature. The problem is most of the time they're wrong or uneven. So we found that all of our pathways, because they are voluntary to use, they would use the pathways where they were unsure. They wouldn't use the pathways where there was hubris. So then there's another condition that happened to us. I'm going to give you 2 more examples and I'll stop, and if there's any time I can answer questions. So the American Heart Association and the American College of Cardiology have recommended that we move to a high sensitivity troponin assay in the acute care settings to assess for myocardial damage. That's fantastic. They were able to get together and make that combined recommendation. The problem is they neither set the targets for what you should do, nor did they set the frequency for how often you should draw your samples. So they left that up to the individual clinicians. Again, efficacy, effectiveness gap. They knew that it was very efficacious, but they didn't tell you how to apply it to the patient. At the same time that that was happening, our 7 acute care hospitals were using 4th generation Siemens machines in order to do regular sensitivity troponin. However, Siemens indicated to us that within 2 months, they would stop supporting those platforms. Most other hospitals across the United States put together a 12 to 24-month plan to implement high sensitivity troponin within their organization. We looked at our costs of buying a new platform, what we would do in variability, and how the chaos would ensue if we weren't able to get in our clinicians' hands how to treat high sensitivity troponin. And we convened a care signature council specifically by our emergency medicine and cardiology physicians about how to use high sensitivity troponin. And they came up with this following, it may be too small to read, but basically, if it's more than 50, if the high sensitivity troponin is more than 52 upon drawing, it's likely myocardial infarction or myocardial injury. If it's between 51 and 12, it's likely. And if it's less than 12, it's unlikely. And there are very specific steps about what you should do next that we built into our pathway. And then, believe it or not, on one day last year, we converted all 2,400 beds, all 300 sites in our health system in one day to this algorithm. And something that no other academic medical center in the United States was able to do is that we just, what we call in the United States, we ripped the Band-Aid off and we made the change in one day. And it changed the world for the cardiologists that were doing acute care consultation and the emergency medicine physicians that were doing many of these evaluations. It went pretty smoothly. And then when we looked back at the results, what did we find? So this is a pre and post evaluation of what we found. I'd have to get a little closer, but what you can see is, numbers are small there. What you can see is the use of echocardiography reduced, statistically significantly. The use of catheterization was reduced. The use of hospitalization was reduced. The use, length of stay was reduced. Mortality, already almost zero, remains zero. So we were able to show that not only were we able to do this in one day, it actually improved efficiency, it improved outcomes, and We, in many of our emergency departments, used handheld troponin point of care testing. We were able to remove all of those because the turnaround time for high sensitivity troponin by our lab was so fast. Now, you can ask my cardiology colleagues about what they felt about the increase in consultations. Bernardo, I'm sure, was right on the front line in L&M on this, doing cardiac consultations. And I think generally now, I think it's been extremely smooth. And we've got evidence that we were able to get complete adoption of this pathway, again, because none of us had ever used high sensitivity troponin before. And it was fully pulled in by the emergency medicine and the cardiology colleagues. How does it address equity? This slide shows in that first set of 3 colored columns, the increased use of consultation or treatment in patients with alcohol use disorder. So as you can see, pre-pathway development, we almost never, about 20% of the time, almost never, we got consultation or we provided drug therapy, naltrexone or other drug, for patients that were admitted that had alcohol use disorder. We've way underused treatment. And we have one of the best, Yale University has one of the best addiction medicine departments in the world. We know what to do, we just didn't do it. Efficacy, effectiveness gap. After pathway, you can see that there was 134% increase in the utilization of consultation in naltrexone. And what's really astounding is usually when we put in changes, it benefits the white population more than the African-American or Hispanic population. We saw the opposite in this. So we can track it by ethnicity, we can track it by race, we can track it by location, and then we can do targeted interventions where we don't see the kind of improvements that we want to see. Alcohol use disorder, very different than high sensitivity troponin, very different than COVID pathways. This is broadly applicable to almost any clinical condition that you're talking about. Here's another example. Chronic obstructive pulmonary disease, relatively small and thankfully shrinking population because of the reduction in smoking. Yet what troubles us is this population has a readmission rate within 30 days that's almost 1/3. Almost 1/3 of these patients are readmitted within 30 days. Why? Because there's inadequate discharge, inadequate workup. So you can see pre and post pathway. You can see that discharge home, total cost, referral to pulmonary rehab, all those were statistically significantly reduced. Length of readmission rate was not. The problem here is that the numbers are very small. Now, why are the numbers very small? Again, because clinicians have been treating COPD for many, many years. Everyone thinks they know how to treat it. We have empiric evidence that they don't. So what are our next steps? Our next steps, I would say, are to accelerate the development of more pathways, to focus on that continuous PDSA feedback loop, and to make sure that we are getting out the outcomes that we need to get in both efficiency, quality, safety, and patient and provider experience. How do we do that? The open question I have for my colleagues who are the clinicians on the front lines is we never mandate anything. We make it voluntary. So without mandating someone, how do we voluntarily get physicians who have been practicing for years, who know what is right, to systematically apply it by using these pathways? Our short answer, our early answer, is that we make it easier for them. We pre-populate the order sets. We bring in the labs that are necessary. We use artificial intelligence to bring in additional information. The only way that you get people to use things is you make it easier. You use human factors engineering to get them there. So, brief talk, appreciate your attention. Thank you very much. I'm